Good morning, good morning. Once again, you guys are having great dialogue, I see. Wow. Well, we're gonna get started once again with this dynamic dialogue, but what I would like to do is make a couple of more announcements before we bring this dynamic speaker back up, which is Mr. Darrell Fox. I would like to have a shout out to the people in the overflow room. To you, those who do not know, we do have an overflow room. And can you guys just say hello to them? Yeah. Hello, woo! Yay!
It's not the wave.
Yes, 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 like the wave, whoosha!
Yeah, it's not gonna work here.
And then also in your folders, you will see the proclamation signed by Mayor Hartwell. Because CHW I recognize, so there's a wonderful proclamation signed by our wonderful mayor. So that is so exciting, so exciting, so exciting. So now we're going to bring up Mr. Dr.
Yeah.
Darrell Fox. Give him a round of applause.
No, let me do it. All right, so I guarantee you by the end of this presentation, you will be tired of hearing my voice, even if I put my baritone voice on, my phone voice. We're gonna shift gears, but I mean, there really is a lot of overlap between our discussion around health reform, access to appropriate care, and health disparities and health equity. So in a way, I'm shifting gears, but in a way, I'm not. I'm just kind of focusing on a certain aspect of it. You saw my disclaimers earlier about not being an expert. That holds true here too. But I'm going to provide some examples and roles that CHWs play in limiting health disparities. I'm going to target somewhat of the chronic disease management, since I've seen that as a major opportunity that I think we are well versed and have data to support our role, particularly in chronic disease management, and how that role could actually help access to care be successful, and the Affordable Care Act implementation more successful. I'm going to talk a little bit about some of the HHS initiatives, particularly the regional health equity councils. Raise your hand if you know about regional health equity councils. Raise your hand if you're on the regional health equity council for this region. Okay. We got some work to do with that too. Because if you're not at the table, that's right. That's right. I want to take a step back, although I know the folks in this room are very well versed around CHWs, but I love the image of the umbrella. We did a lot of work, had a lot of practically fistfights around a term we could work with when we coined the term community health worker, which really is a newer term for a profession, a field, a group of folks that have been working for a long time. Creating synergy, no matter what title you have. We heard that with the MITRA presentation as well. That's a critical component to heightening awareness about who we are. So I wanted to not go too far without talking a little bit about the basics of CHWs as a reminder and as something to say no matter where I am, what presentation I do, even when it's with fellow CHWs, I sometimes talk about this umbrella, the term, the definition, because everybody isn't aware of this. I love images. This is us, we are they. I mean, no matter whether I'm an asthma educator, an HIV educator, a diabetes educator, if I engage that family correctly, if I visit that family and I'm there to meet their needs, I really have to learn how to do these and be able to switch those hats off and on. One of the big challenges of being a CHW with a big heart is the boundaries and barriers. I mean, the boundaries we really have to take care of ourselves. If we take care of ourselves, our clients will be better off as well. So while we have these hats, being cognizant of some of the boundaries we must have as a workforce helping people. For about a year and a half, there was a major undertaking related to creating a national definition for CHWs. It was led by the American Public Health Association CHW section, but there were hundreds of CHWs, allies, partners, supporters around the country who had input into this definition. And also, when we submitted to the Bureau of Labor Statistics, they were inundated with over 1,100 comments. And normally when they propose a new classification code, standard classification code, they don't have that many comments. So they were amazed at it. So once again, an opportunity. There's a lot of people, whether you want to call it bandwagon or not, who are coming to the people, CHWs. But what we do when they come is critical. So understanding who we are is one major piece. So this is the definition that we submitted. And you'll see some highlighted areas. Whether some states and cities actually have definitions, some CHW associations have definitions. There's a movement afoot to see if we can synergize a national definition by having networks, associations, cities, states adopt the APHA definition, but that movement's just starting, but some already have, as we've heard here in Michigan. Trusted member and/or have an unusually close understanding of the community. Liaison, link, intermediary, you'll hear things like cultural broker, and all those things go both ways. So me at the Harvard teaching hospital called Boston Happens for 20 years, my role working with those folks within the institution, within the administration, was as critical as my role working with the clients in the clinic and on the street. Two-way street, we're brokers each direction. I think that's something that we need to remark on, particularly when you're talking about limiting health disparities, because you have to address what's going on in those buildings when the people that we convince to come in get there. If there's issues and challenges within that building around culture, et cetera, they will not come back. They'll go to the ER or whatever, so it's really tied together there. And here's more about building individual and community strength. Now, they didn't end up using this definition for the standard classification code. Raise your hand if you filled out the census in 2010. For CHWs, raise your hand if you ticked that off on the form and you wrote CHW on there. We got to get more CHWs on the next round to do it. 38,000 people ticked that form off, but we know, based upon the HRSA workforce study in the country and other things, there's at least 100,000 CHWs out there. I think there's more, and I know I saw a couple of figures for Michigan. I think they did an assessment in 2012 about how many CHWs. So, but they do use this definition, oddly enough, in another area, and it's the CHW Registered Apprenticeship Program. You guys know about that? You guys should look that up. I mean, it was one of the successes of us submitting the standard classification code. It opened up the avenue for some funding for apprenticeships, and so those are currently happening now. This is the current classification code definition that they have, and that they have for the Bureau of Labor Statistics Standard Occupational Code for CHWs. You'll see a note about health educators, because there was talk about integrating the CHW definition into the health educator, but SOFI, the National Association for Health Educators, and others had challenges with that, and so they added this clause in there for that. And there's different reasons for that. We could talk offline about that. But you'll notice this is a very medical definition. We understand that a lot of our work as community health workers is non-medical focused and non-clinical focused. So we are trying to go back. There's a window of opportunity, once again, a window, where they're re-looking at some of these, I think, within the next 2 years. So we're trying to start to drum up support to get them to change that definition, because we know it'll be used in other places, and we want to have the right definition defining our field out there. Part of the reason why you hear me talk about CHWs being involved, engaged, and not just that, being in leadership, is because we have some different mantras that are out there. Nothing about us without us is one of them. And then I'm into the Nguza Saba, Kwanzaa principles, but Kujitagulia, self-determination, is also one of our rallying cries. And we've actually done presentations around self-determination for our workforce out there. So now I'm going to make a shift to just briefly some definitions around health disparities and health equity. And I've been one of the people slow to move to the language of health equity. I have different reasons for that, but I'm now talking more about health equity as well as continuing to harp on disparities because I think it's important. The image you see there is from a documentary called The Deadliest Disease in America, which was about racism, bias, and other kinds of things that impact ability for people to be healthy in the US. And so I thought it was a very catchy phrase to use related to that. Health disparities, basic definition. Significant differences between one population and another, and the overall rate of disease or incidence, prevalence, morbidity or mortality or survival rates. Basically differences within those items. So this is what I use as a standard working definition for health disparities. There's another way I've seen it written out, which pulls in the word inequality within it and talks about the different populations of people. Are people very familiar with these definitions of health disparity and health equity? Okay, very good, thank you. Health equity is the attainment of the highest level of health for all people. Now this requires valuing everyone equally. Valuing everyone equally. Is that something that has been the hallmark, let me not get unpatriotic. Is that how things have been working in the past? Okay, so to really achieve this vision of health equity, we have a lot of work to do. Now I'm going to focus a lot on some of the things like chronic disease management, et cetera. A lot of people know, but it's hard to take on poverty, racism, all those things that some of you want to stay away from sometimes talking around the dinner table. But if we don't address some of those, we won't get to this vision. There are things that we can do and roles that we can play in kind of reducing disparities. I'm waiting for the next Healthy People 2020, then 2040, then 2080. We just keep moving the target down the road a piece because we can't focus on trying to address what are some of the root causes of these inequalities. The fact that people are sick longer, the fact that some people get sick and die while others get sick and get well, it's a sad reality, and myself as a community health worker and a consumer of healthcare, I deal with that my own way, but I think as we talk about our role as CHWs in eliminating health disparities, I think we really have to take a good look at how we can make a dent in some of those bigger things that are really hard to tackle around racism, poverty, et cetera. We know that place matters, where people live. If we help people with their social and living environments, we know we can help people stay well longer. But how do we do that in a climate that says we don't have the funding to do that, or we don't have the will to do that and make a change for everybody and have everybody be equal? So that's my soapbox for part of this presentation for today. And I hope a lot of people are there. I see a lot of nodding heads, but it's how we, in concentric circles, within our spheres of influence, get others to kind of understand this, and how do we address those root causes, and how do we use funding that might be prescriptive, Fed, state dollars that say you got to do this, you can't. How do we be innovative? We have to do, don't get me wrong, we have to do what the funders want us to do, but how do we do that with the lens of knowing that it's going to impact health equity or health disparities? It's a different way of thinking, and we can do some of the same things, but have a different way of thinking about it. Anybody know this song? Stony the road we trod. Okay, so I've gone to presentations over and over and over again, and I see all kinds of pie charts. I see all kinds of information year in, year out. I see studies that come out of communities that I know from 10, 15 years ago where they developed sort of kind of a solution or a way to address it. But then when you go to that community 15, 20 years later, the same issues, almost some of the same statistics are evident. So we got some issues. In many, many years, we've dealt with some of the diseases you see on the screen, but still we have not made good headway in some of these areas. And there may be some reasons why, and we'll talk a little bit about that today. Bit of the chastening rod. So poverty, racism, housing, all of the social determinants of health really make a great impact on a person's health and wellness. And we've continued to see in urban areas and even in some rural areas very disheartening figures around rates of poverty, issues around housing, incarceration, et cetera. We got to address some of these if we're truly going to make a dent. And I think CHWs are poised because of the walk in life many of us have had to help others address these issues. And I always remind people, and I purposely didn't show people pie charts, and there's a lot of sources of information to get this data. But I always see the faces. When I look at HIV stats, I see the faces of the clients I've been working with that have grown up with HIV. And sometimes I see people get disconnected and look at the charts and think of it as just numbers. And I think the real beauty of being a CHW is seeing the people. I think it has a different effect on me when I look at a pie chart and I'm thinking of the individuals and the people and stuff like that. So, any of this making sense to people? Am I just rambling, or how y'all doing out there? Disparities data. I've seen some really good data. I think it really helps us. Somebody just brought me information about some data here around CHWs and some of the work they're doing. And I think it's critical that we collect the data appropriately and use the data appropriately. But I think there is some challenge just even in that, even in how people are classified when they come in the front door, et cetera, and self-report. And so I know that there are federal and state initiatives around how to better collect and analyze data, and I look forward to people sharing some of these new strategies with me soon. And that's what this is about, the fact that people are trying to create reports that are more usable and tangible, not just for those of us who are involved in this movement related to CHWs, health reform, and healthcare, but for the consumers, for the people who are part of those statistics to actually understand some of this data. I like to quote theologians and rappers. There's a great rapper, Jada Kiss, used to be with the Locks. Raise your hand. Okay, no. But there was a song he had, Why, and it was really asking about a lot of social conditions and asking the reason why. I think there's been a lot of people for a lot of years that have tried to answer the question why. We've seen tons of reports from people like the Institutes of Medicine, and I always cite them because when reports, for some reason, come out of that unit, people actually listen. There could be 1,000 other reports. There could be people talking about something, but it seems like it's validated, which is challenging for me at times, by groups like this when reports come out. So, but this report actually had a specific recommendation around CHW, so I cite this one a lot. But part of the reason we have to continue to ask the question why is that is going to be the only way to find real solutions for the real reasons why we are where we are related to health disparities. Another mantra, don't talk about it, be about it. And as the great theologian Master P used to say, be about it. Okay, some of y'all laugh, so y'all get that one. And so I think forums where we talk about health disparities is great and health equity is great, but taking that and translating all of those studies, all of those discussions to action on the street is, I think, really where some of the conversation needs to start flowing. So understanding disparities is one of the key steps towards action. Involvement in leadership and community-based solutions and strategies to end disparities. I've seen several coalitions that have been grassroots without a lot of money who've actually made an impact in some of the communities that I've lived in over the years. And I hope that's happening here. I think understanding that we all have a role to play, and once again, I talk about in our spheres of influence, in our concentric circles, talking about some of this work that we do, ensuring that others understand the work we do, and hoping that they can become agents of change in their sphere of influence. And I think that's where building relationship with providers, administrators, policymakers is really critical to how effective we can be in being about making a real change. I love the bumper sticker. I guess I got to figure out if I can get one for a discount price. But Got CHWs is something that we kind of went around for a while in our state as we were trying to heighten awareness about our workforce. And I think CHWs are not the end-all, be-all. I had a great conversation with someone here in the room about if we get all of the credit, then when something doesn't work, we're going to get all the blame. So we're not the end all be all, but we are a major piece if we're truly going to make a dent, so that when Healthy People 2040 comes out, it's not just shifting the year and having the same goals, but that we've actually made some dent and impact in those goals. Anybody involved in the Healthy People 2020 reviews? Okay. It's an interesting process to go through. There's always open comment periods. I urge people to review it because they kind of start to funnel a lot of resources and a lot of the prioritizing in the federal government and all of their resources towards those goals when they come out. So if you have the right kind of goals, you can get the right kind of resources towards it. And if you're involved in defining those goals, I think we can do a better job of making an impact, a real impact. Community strategies. And I'm purposely talking about some of the things that I'm hoping we are doing on the ground here that I know happens other places, because many times when you talk about health disparities, health equity, it's all about the problem and the numbers. So I'm purposely not doing that. I know there's a lot of people disappointed in this room because you wanted to talk more about the problems, but we'll get to some of that maybe if we can. The deficit model does not work well, particularly in the populations I work with, which are mainly young people. So really going to those esteem and resiliency factors. I mean, the fact that growing up in a housing development in the Roxbury section of Boston, there were a few people who made it, who were successful, who, in spite of all the odds, have gone on to do great things. And there are many who didn't make it. Finding those people and talking about those people who make it and help them talk with their neighbors so they can all make it is something that I feel is very important. So trying to build on not deficit models, but asset-based models is critical. Even the language we use is more deficit-based. It's all about what we don't got or what a person doesn't have. And I purposely use wrong English if people are wondering. I think that really helps personify or help continue some of the issues that we face. So trying to get a person to understand that the solution to their health issue and other things are within them, their family unit, and their support is a model of reducing health disparities that I've seen work in many places. Popular education, where you're really working with people through writing, through images, through video, and stuff like that, has also been a solid strategy around that. Health literacy, I think I'm going to talk about that later, but I just want to say that there's a lot of assumptions around the reading levels and health-related literacy of folks when consuming the millions of brochures, pamphlets, documents that we have. People need to really assess that for the population they're trying to reach and to design things that will actually reach them. And I think through popular education and some of the different media uses of how to relate information helps people understand it better than the handout at the end of the clinical visit, et cetera. And then advocacy coalitions. I think there's a few places I'll talk about later that really talk about health equity, but it's almost like, as I said with the CHWs, we can't be sitting in a room with just CHWs all the time talking about CHWs. We have to be talking with other people about it. We can't be sitting in a room at a national health equity conference and it just be people who are all working in the field, who know the acronyms and the lingo. It has to be others and community folks. And so I think building coalitions that bring people from K through 12 education, as well as higher education, community-based organizations, and just plain old consumers, community members, at the table in equitable ways, not just tokens or what have you, is a way to kind of do that. And I've seen some coalitions around health equity kind of build those kind of things. One of the things that we've done, and I don't know how the relationship with other states, because it seems like the disparities and inequities cross boundaries of states, but trying to learn from other states in our area, in my region in New England, has been something we've done for years. From 99 to 2009, we had a coalition that met monthly, that had community members, consumers, people from the state offices of minority health, and the health departments, as well as federal folks from our Region 1 office, created this group that had a major conference every 2 years, focused solely on health disparities, health equity. We stopped doing that in 2009 when the emergence of the regional health equity councils came to be, thinking that those might be the new place to do some of that work, and we're kind of reassessing that now. But this was a real way to heighten awareness. We moved it around to each state because there were some states in New England that weren't moving forward as progressively related to addressing health disparities as others. So we purposely held it in each one of the states, and I won't name the 2 states in New England that had issues there. There have been some really positive happenings that have brought people together from around the country. I'm not sure if they continue to happen, but the National Leadership Summits on Health Equity, which created something called the Blueprint for Change, that I'll talk a little about later because it created the National Partnership for Action, the NPA. Minority Health Month. Raise your hand if you have hosted activities, events, and have helped to heighten awareness around particularly issues around disparities in communities of color in the state of Michigan. Raise your hand if maybe you'll start planning so next April. All right. All right, thank you. I think there are some changing paradigms related to health equity, health disparities that are really focused on some of the issues around prevention. As more and more data gets out there about the cost of illness and the cost of death, it's sad that that's what it takes, but sometimes things change. When there's revolution and blood on the streets, things change. Forgive my analogy with the war, but I think also the fact that we're getting better data on health disparities, and we're actually seeing widening disparities even after multi-millions of dollars have been spent to address it in some areas, is making people kind of rethink and once again maybe transform how we talk about health disparities. And also the aging population. A lot of stats on how many folks over 50 we'll have in the next 20 years have helped people kind of talk about the fact that we have to do a little bit more prevention. And we know as we start to age, whether we are healthy and have no major conditions or not, things just start not to work. I know that, and I'm only 49. And so understanding that we could be looking at some alarming rates of disparities, more alarming rates of disparities with our aging populations has also helped people say that we have to probably get in front of this. And I think Medicare and others are starting to understand this. We already talked a lot about the federal health reform, and I think having some provisions that will definitely help us address health disparities and health equity are within that, and then different state health reform, the patient-centered medical homes, and also some of the ACOs. There are some ACOs that look like they make a lot of sense and that will increase access to regular folk who are dealing with illnesses. There are some that do not. I don't know where you stand in Michigan with ACOs, but I urge people to also take a look at them and look at the potential they have in helping to address health disparities. The good thing is the data. I've seen a lot of new data around outcomes because people have always said, well, what are CHWs really doing? It's really hard to isolate my intervention as a CHW from every other intervention. I know there's some interventions that have double-blinded studies and other kinds of things have tried to isolate that CHW intervention from others, but I think more and more people are making the leap of faith, understanding that that intervention did make a difference, but then trying to find some way to measure how it made a difference and what that difference was using some of the outcome data. So you'll see several items here around just us helping people sign up. I think there's data on people who have insurance coverage versus people who don't have insurance coverage, major disparities in their health outcomes for different reasons. It's not automatic that having that card gets you better, but it does help in some case several people who've not had access before, not had coverage before. Preventive services and screenings. I mean, this is, once again, there are several outcome studies. I think I'm going to mention a few later on in this presentation. that talk about how screening and education, et cetera, has actually helped those bottom line clinical outcome figures that a lot of people are so interested in. We heard a comment about primary care, and it's a very critical piece of how we address health inequities as well. And we also talked a lot about the urgent care piece and trying to reduce the unnecessary use of, or the appropriate use of urgent care and emergency rooms, et cetera. Here's some general statements that I like to make. There is evidence to back this up, some of which will be presented today. Some I know there are programs that have information in your state, specific to your state, that show some impacts on, particularly on some of the illnesses, diabetes, asthma, high blood pressure, et cetera. Patient health literacy, working with clients to better understand healthcare information, healthcare systems. I've been guilty, and I know many others in this room maybe have, and our clients, of nodding while we're getting that information. And do you understand? And then some of the good providers know, they say, tell me back what I told you. And then you realize that all the nodding was just active, semi-active listening because they didn't get it. And they leave, they don't take the medicines right, they don't do some of the preventive stuff right, and you're back where you started. So CHWs have a major impact in helping that literacy. Also, we were also afforded more time. I think being tied to 12.5 to 15.7 minutes per visit for some of the providers that are out there is not appropriate for the kind of care and dialogue people need. So we have an opportunity in some settings to have a lot more time with those clients, but to really support what those providers are saying in those 12 to 15 minute visits as well. And strengthening cultural competent provider practices. I mean, there's a lot of talk about how we can diversify the workforce. There are studies on diversity of the healthcare workforce. Some areas of this region, woefully poor. The country as a whole, woefully poor. So there are ways you can do this. You can diversify the workforce, but in the meantime, how do you, so you can have people who are diverse on the teams, but also how do you work with providers to ensure that they can better serve people who don't look like them? In most of the health centers in my area in Boston, most of the providers do not look like the people who are 80% of the folks coming in. So you address that by diversifying the team further, but you also address that by working with the providers who are there, and I think you need to do both. It's an and, it's not an either or, it's an and both. And so that's a thing that CHWs have also helped to do. I'm probably doing divergence, so if I go too far away, somebody just put their hand up and go like that, and that'll bring me back to the slides when I'm supposed to talk about. There's a lot of research evidence that really talks about the strength of CHWs and the fact of that diversity being a major strength on how we are effective in reaching certain populations of people. And there is some evidence out there of that. Although we are highly effective with vulnerable populations related to people who might be poor or racial ethnic minorities, I think there's also growing evidence that even with workplace wellness, even with middle-class people, even with folks with money, having that health aid, having that CHW, that navigator person, actually helps their clinical outcomes as well. Because I know some very hard-working folks that have money that don't take care of themselves, and then they end up in the ER and having to do something that they could have prevented. So it's not just poor folks, and that's another one of the strategies for selling expansion and enhancement of CHW's role is we don't just serve just communities of color, just poor people. We pretty much serve everyone. And so I want people to note that as well when we talk about that. And here's another plug for CHWs on a team. When we're valued and respected and really part of a team, these are some of the things that we do to help for that. And I won't belabor this point much, but I wanted to note this. So now I'm going to shift to a couple of things, and that's around the public health workforce, and then I'll go into chronic disease management. So these are some of the things you've heard me already talk about. These are things that we do every day. These are things that we addressed even earlier. But these are directly related to eliminating health disparities and promoting health equity. And that's the population health literacy, individual and population health literacy, culturally and linguistically appropriate care and services, outreach and enrollment, and most importantly, retention. and things like health insurance, health homes, et cetera. And then addressing the barriers, knowing what those barriers are, having a relationship with people where they tell you the real deal on what the barriers are, and being able to address those is a critical piece. And once again, you will hear a lot of themes repeating. There's no mystery on why that is, because health equity is so integrated into the stuff we talked about earlier. I love to use terms related to CHWs around the public health practice and the fact that we are actually primary and secondary prevention practitioners. You know, a lot of people talk about, I think it's labels and the way we refer to things are important, and I think this is something that on the ground, this is what we do. For instance, I used to go talk at a couple of those schools of public health, and they would toss out, I would hear things like Bandura, Jesser and Jesser, DiClemente, all these theories, social cognitive behavior change. And I said, I know many CHWs who actually don't know the names of those theories, but they are putting it in practice every day. And I think some of those models may have been enhanced by actually them observing the work of CHWs. I don't know, I haven't been able to interview Jesser and Jesser or DiClemente or Bandura, but it seems to me that long before those models were in those books at schools of public health, there were people on the street making them happen, and some of those people were CHWs. And providing a community perspective is really important. I know there's a lot of public health professionals who I know, a lot of clinical providers who I know, who are really engaged in their community and really care about their community. But I think CHWs bring that perspective, particularly those of us who've done outreach on the streets and have worked in some really rough, tough areas where other people would not go. It's a very different perspective that's needed at the table. I'm talking about going to shooting galleries, working with active addicts. I'm talking about alleyways. I'm talking about giving condoms in areas where people are turning tricks and working on the street. That's the kind of things that you sort of kind of can read in a book and maybe get a little bit of effect, but when you do that work, you understand what would help those people get out of the situations they're in, and therefore that perspective is very important. How do people feel about that? Yeah. All right, so tonight we're gonna go to the spots as a group. We're gonna do some, I brought condoms and stuff with me. We're gonna go and we're gonna do some street outreach tonight in some of the toughest places. Who's down with me? Oh yeah, that's it. That's how you eliminate disparities for real instead of just talking about it. Thank you. Emergency preparedness is another area. It might not be as related to health equity, but I wanted to add that in there because a long time ago, there was a gentleman who used to be part of the leadership of the Center for Sustainable Health Outreach, also known as CHW. And he did a white paper on CHWs and emergency preparedness. We felt that while money was running in the streets, at one point it really was, around emergency preparedness, being used in all kinds of ways, that we could integrate CHWs in that, again, as a way to diversify our role. That didn't happen, but as you all are thinking about what you do here and how you address disparities, people say, if there was a major catastrophe, I can evoke things like Katrina, but there's been a lot more recent things. Who would be the people who could get the right information to the people or help people be prepared to deal with that or help people get out in time? People died. The disparity between people who died and didn't die during Katrina was very real, and it was about a lot of things around inequities, and even about inequities on access to information. And so don't let that get off your radar screen when talking about health equity. Emergency preparedness, I think, is a part of that. And these are other things that we do all the time. I mean, I always talk about working on the outside of the walls of the institution, no matter how much I'm indoors, in the clinic, doing testing or whatever kinds of things. I feel it's very important to get outside the walls of institutions. And so we always talk about the complex systems of the healthcare system. This is just a brief snapshot of the pieces of our public health system. People need help navigating this. The more our folks know how to navigate public health systems, the better off they are at preventing illnesses, injuries, et cetera. And so these are just some of the things that we have to go through and help people navigate. I just like that graphic, so I borrowed it. So don't keep pointing at the healthcare system as being broken and being complex. Even our public health systems are broken and need some support. Chronic disease management. Improve some of the things that CHWs do related to that are improve access to the most efficient and effective care services. That eliminates disparities. Provide outreach and appropriate health education, particularly finding those who are lost to care. I know there are many systems that have things in place that can flag folks that have been out of care for a while. I'm not sure how systems in Michigan do that, but the way we've done it at some of the systems in Massachusetts have been around flagging folks. They do the letter, document the letter, another letter, call, then it's dispatching someone to get out and find that person. That's been a way we've been able to, I think, help reduce some disparities in our state. Okay, I already said this kind of thing. Partnerships with clients. I think when the power paradigm shifts, where the client feels as in control of their health care as the provider, it makes things happen within people. I think many CHWs, some became CHWs, some patient navigators became patient navigators when they understood that they were the ones that probably should be in control in decision making. Yes, the doctor knows what regimen of meds is preferred, et cetera, but being part of that paradigm and being part of that is a major thing that we help, I think CHWs help. And this is a two-way street again. This is working with providers to help them understand that they need to work more in partnership with the patient when they need reminding. Not all providers need that. And then us working with the patient saying, no, you don't just shake your head and say, yeah, you can actually question that. You can ask that question. So that's some of the stuff that we do. And then medical case management and community case management are critical components to any efforts to truly eliminate health disparities and keep people well longer. Chronic disease management, I want to talk a lot more about. So this was the one of the meetings that really tried to bring together people who work in the field focused on health equity and health disparities, hundreds of presentations, representation from pretty much every state in the country, a wide variety of people attending, and this is where I learned a lot about some efforts that were going on and some best practices in other places and bringing that back home. The National Partnership for Action to End Health Disparities. Okay, this goes to the people in the overflow room too. Raise your hand if you know about the NPA. I see 2 or 3 names. Okay, and in the other room I see, okay, 3 or 4. I can't really see them, but I'm playing. This was supposed to be, this is the goal, increase the effectiveness of programs that target the elimination of health disparities. So imagine there's been federal agencies, some who haven't been talking with each other, who have put multi-million dollars every year out specifically to eliminate health disparities. Some that have benchmarks, goals, et cetera, and others that are about heightening awareness. And imagine there was no coordination. So as dollars shrunk, people had to come together to figure out how do we do, in that term that nobody likes to hear, more with less. And so this NPA that many people in this room don't know about was supposed to be that effort nationally, not just for the feds, but for all of us, to be part of a new system around addressing health disparities that would be more coordinated. The fact that we're not talking about it here, and there is a group in this region that's supposed to be helping folks get there, is not good, but I think having this dialogue today and some of the thoughts that I think will happen during discussion may help us move in another direction and start to get involved and engaged with this. There are 5 major goals or sections of the National Partnership for Action, and there's also something called the National Stakeholder Strategy for Achieving Health Equity. And they are around awareness, something that I know we are all doing in here, around increasing the awareness around disparities, the impact on the nation. Sometimes you have to do it in dollars and cents, lost work days, lost productivity, et cetera, some of the things. Leadership, something that's woefully needed around leadership to address health disparities at all levels, home, work, community, et cetera, education. The health system and life experience goal is really focused on trying to transform the sick care system that we have to better serve different populations. Cultural and linguistic competency goal focuses on exactly that, trying to ensure that we're enhancing the ability for people to have appropriate access to culturally appropriate and linguistically appropriate services and materials. And then the data research and evaluation goal is really about not just collecting the data, not just showing the pie charts on the percentage of people in the country and then how many people are impacted by heart disease, by HIV, et cetera, but how do we use that data to create some action? And how do we evaluate what that action is? Also, as part of the National Partnership for Action, there is a specific portion of it that addresses promotores de salud and CHWs as well, and it's created a national work group, et cetera. And so once again, this was an opportunity for us to explicitly get involved in health equity, health disparities conversation that we didn't have prior to the MPA. Regional health equity councils on the ground have been the place where a lot of the efforts around this National Plan for Action, Partnership for Action, has tried to do the work. There are some that are still in their infancy stages of organizing. Based upon what I just saw, we need some of you all to be involved in the RHEC for this region. And as you'll see, that's the cluster, Region 5, for your RHEC. And it's important that we have CHWs that are part of that. I think there are some outcomes that will come from the regional health equity councils that will improve and enhance health equity. I have to believe that because I'm on the RHEC for my region. One of our goals is actually focused on the role of CHWs in enhancing health equity. And so just by being at the table, I was able to influence the fact that we only have 2 overarching goals, and one of them is around CHWs and health equity. So I think there is a place for us in the RHEC, and I think it's gonna be a way in a more organized fashion, I think, to address health disparities and health equity. And this tells you a little bit more about the health equity councils. They're in all regions. What I will say is there's not a lot of resources. It's run out of OMH. The first year, there was funds for in-person meetings and a lot of TA work. Now, I think they fund 1 annual meeting for each region, and they have a TA contractor who assists, but there's really no other funds to help that group do it. So it's really, really dependent on volunteers that are part of the Health Equity Council to find resources and to lend resources. And that has worked in places where some of the non-usual suspects, some of the private partners, some of the health foundations, et cetera, are actually on the RHEC and have helped bring resources to do community forums, to host screening sessions where they have hundreds of people come through where they can get cholesterol, blood pressure. These are the kinds of some of the things we feel, will make an impact for real on the ground with communities around limiting health disparities. And once again, that's that window of opportunity with this National Partnership for Action for all of us to get engaged and involved and do some other things. Hey, that is not the right version. Un momento, por favor. Sorry, y'all, here we go. Let's see if I can get back to. So these are some of the data, and I mean, these are some studies. These are some brief sentences on some of the studies that are out there. There are a couple of articles or publications that actually have pulled together many of the studies in one place, which I think some people need. It's an easy way to find the information. And so I pulled some of these from there. And this was around some of the successes around self-management programs to impact equity and reduce disparities. So this is one of the studies from '99 that showed statistically significant changes and improvements in hospitalizations through a self-management program that was a 6-month project of learning and education with the patients. You got a Missouri diabetes program, has a small number of people who were part of the study, but it showed, once again, statistically significant changes and improvements in some of their clinical indicators. And these are some of the things that we must continue to do and collect the information. And all of the information I'm showing you here have made an impact on health disparities in the areas where these data is coming from. And these focus on different things. I'm not going to read them all to you, but just take a look. And these are some of the things that have happened. Community health representatives in tribal nations have done a lot of work, particularly around diabetes. And there's one great study that I found that really talked about the role that we played in creating change. Some more studies related to whether it's diabetes. And I find the body of evidence for diabetes and for asthma, people have been doing their work in those two disciplines, a little bit less with heart disease. But I think that I advocate for the generalist approach to care and the generalist model. I think that many CHWs who become specialists in HIV, in different heart disease modalities, as well as diabetes, et cetera, I think it's important to have those specialty areas, but it's as important to have that generalist model, because as I'm working with that HIV positive client, I find myself working more with their hepatitis C, their liver disease, have to understand that more than their HIV. And I think that's a critical component as well. Some critical ingredients around the real disparities elimination is acknowledgement of preventable disparities. There's still debate today raging around why some disparities exist. I think there's a lot of blaming of the person. And yes, we have to have our responsibility for our personal responsibility for our health, but there are some things in the society and socially that actually help people stay not well. And we have to understand that while not blaming the victim for the situation that they are in. Sorry if I couldn't articulate that well, but I'm still kind of formulating some thoughts about that. The will to address the issue. I know there are some states in this country that have actually taken on full force the elimination of health disparities. They've integrated things like health in all policies, when they talk about community planning on the local level, et cetera. And there are many places who have not. So I think the will to address it is critical. That includes the political will, and I don't think health disparities, health equity belongs to any one party. I think everybody should be engaged and involved, but it's been very challenging with some to get on there with the more economic and political arguments around eliminating disparities. Commitment from leadership. I think governors and states, I think state health departments have a critical role to play in modeling some leadership related to the importance of eliminating health disparities. And then resources, we all know about that, and accountability. So I won't say any more about that, but I just wanted to add something which I call the menu of ingredients that really make for good, solid, real elimination of health disparities. Not just talking about it, but not just talking about it, but being about it. All right, I'm just trying to make sure people are still awake. I've been talking way too long. I got to finish this up, and we need to get to some conversation here. What can we do? It's critical that we share stories and data. We must heighten awareness. There are people, we have ads in HIV/AIDS now that say HIV/AIDS is still an emergency. There are people that think you can take a pill. It didn't help calling them cocktails when they first started doing medications. But a lot of people don't think there's a sense of urgency. And I think we really have to focus on enhancing the fact that this is a state of emergency for many people around health disparities. Local capacity and solutions, I'm an advocate for that. Political and systems change, that's easier said than done. Framing issues around disparities and agendas, using common language. I've seen people do very well at framing the dialogue and debate around equity. I talked earlier about people who talk about lost productivity, people who talk about lost time in school, lost time at work. For some people, that's what resonates. People dying, people hurting resonates with me. Some of the other stuff resonates as well, but I think you have to figure out who the audience is when talking about this and figure out what are those arguments, what are those points that will resonate with the group. The root causes, okay, I'll never leave the social determinants of health. Those will always be something I feel are critical to the health and wellness of everyone, but trying to help others get there. I always talk about root causes, unnatural causes, which, great. Raise your hand if you've seen unnatural causes. Awesome. Growing up in the projects, I always knew place mattered, but having it be really articulated well and being out there, I think, was important. And I urge everybody to use portions of that as a tool. I know it's getting dated now, but I still use it a lot. Collaboration with community health workers and the RHECs. I was saddened to see only a few hands go up when I said something about the RHEC. I'm hoping some people in this room are committed to changing that, understanding who is on your Regional Health Equity Council for this area, seeing what you can do, seeing what they're doing, and seeing what you can do to help, and maybe synergizing your efforts with them. Again, the whole plan with this National Partnership for Action was to better organize the multi-millions of dollars that are out there in the name of eliminating health disparities, to really organize it in a better fashion and use it more effectively and efficiently, particularly since those dollars are shrinking. So all of you play a role in that. Because I have time, there was a lot of resources that are on this presentation that were for both. And so there are some articles that you will see. Several citations are on the IOM website that has a lot of data, a lot of information, but more importantly, there are some reports that are around solutions to disparities. For the health reform presentation, I pulled from every source that I could. It's all out there. I tried to put links on here for people. I know this is a lot of information to get, so at your convenience, you can go to some of these links to see some of the information that's here. The American Public Health Association has a few policy briefs around prevention, wellness, around the Affordable Care Act. I hope many of you all will be attending the annual meeting, and there's going to be a couple of special sessions, particularly around the ACA and public health. There's actually a special, all-day special session related to that, as well as other sessions during it. You'll see Community Catalyst listed several times. That's a national advocacy organization around healthcare. They have a very easy-to-use website, a lot of resources, particularly because they engage consumers a lot. So you'll see a lot of materials that are really appropriate for sharing with clients and community members who are not part of our choir of folks who are engaged in this already. Unnatural causes, I use that tool, particularly with youth. I want to mention something I haven't mentioned before today. There's a group called the Institute for Clinical and Economic Review, and they have something called the New England Comparative Effectiveness Public Advisory Council. They are people that usually look at medical procedures and talk and look and compare and contrast certain tests and procedures to other tests and procedures. This year, for some strange reason, and I think it's because of the heightened awareness around CHWs, they decided to focus on CHWs. So in June, a couple of months ago, this group convened to vote on the comparative effectiveness of CHW interventions. So this report has, they're very analytical. The people, you'll be able to see the names of the people who are on it. I think we were very nervous at first. Who are they? They've never interacted with us. Excuse me, this is CHW saying this. Who are they, and how can they vote on whether we have value in healthcare, human service, public health systems? But once we got over that and said, we better get to the table, because if we don't, we know, okay, thank you all for this call and response. This is beautiful. And some of us gave testimony, and it was great because some of it was passionate from the heart, which was a great thing to show in public for some folk. We, I think, influenced, and every vote they took was around the value and effectiveness being either high or I forgot the other rating, but very high. And what you'll see is their process. This was a very analytical look at what we do as CHWs. I think it was a great thing that they did, and I think the report is a good thing for a lot of people to take a look at, and it's now available online, the outcomes of their review that they started maybe back in February or March. And they pulled together so many references. I've never seen that many CHW-related outcome data in one place than from this group. So, and they tried to get more updated resources as well. So you'll see some of the newer studies that came out were part of their process. So y'all, we've talked about health reform. Earlier today, we've talked a little bit about health equity, health disparities. If people want to ask specific questions around health equity, health disparities, we can take time for that here, but I really want people to be thinking about what is it that you, personally you, your organization, the people you know can do around some of the opportunities that have been talked about today to make a change and impact on access to care, on health disparities and health inequities. Because I think that's where the discussion has to go, and then once you talk about it here, you have to then be about it and implementing when you leave. And so I'm hoping that will happen, and I'm hoping my 2 discussions have helped people think maybe differently about things and stuff like that. So I thank you guys again for your help. Questions, thoughts, reflections, comments? Somebody say something about what you're doing around limiting health disparities, something that has some evidence that you want to share?
Hi, thank you for your presentation. My name is Hannah. I work at Arbor Circle with early childhood programming. I had a question for you around the ability to advocate in the workplace for legislative reform and kind of creating macro level changes. I feel like given the economy and just the push from funders to increase productivity and so forth, it creates a, I don't know, conflict of interest to take that time, as well as different organizations' policies and rules around
Like
actually
lobbying.
Engaging in political action. So I wondered if you could speak to that a little bit.
Yeah, I know there's like 501c4s that can do more of that kind of stuff, but 501c3s, there are some prohibitions, but educating legislators and policymakers is not lobbying legislators. I think there's even if you were calling it lobbying, I think there's a certain percentage that as a 501c3 you can have resources towards to do that lobbying. I don't know, your question was interesting because I think if somebody's caring about the health and wellness of people, and you're figuring that if we made a change in policy, for instance, I can help a family one at a time on the ground, and I can help them navigate the welfare system, the housing system, what have you. But I can help 1,000 families if I see something that's either being obstructive to people getting housing or getting the right services. And so it makes sense in a way, it might even save time and effort if we could do some advocacy around systems change. And that's kind of the argument that I would say is if I can propose a change in a policy that will help 500 clients in one fell swoop versus me helping one client at a time for the next 3 years to get there, then I would think you would be willing to accept that. I don't mean that while you're on company time doing specific lobbying things. I mean, we have an advocacy day at the State House. We have City Hall advocacy days, and I know other states do as well, where it's all about educating. It's educating about who CHWs are and educating about some things you feel important about. So those things, we've had employers release people to participate in those, but it's all about how you're framing it, what kinds of things are going. We usually do a little training at the State House or at the City Hall along with that, so that kind of helps people kind of release folks. But I think it is good to be clear about what you're doing if you are talking about changing particularly legislation or advocating for a certain kind of legislation while you're at work. I think you need to know what your policies are for your individual place. But a lot of people go back to, well, we're 501c3, we can't do that. And I've heard several times that's not the case. And I've seen a presentation that kind of cites the section that talks about things you can and can't do, and then how much effort you can put towards those. Right? Yeah. 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 Yeah, I always have said, because our statewide association started focused on policy, that policy was really synergized with the work that we do, meaning everything that we do, right, helping that client get a service when that service really said they weren't eligible is advocacy. And and shifting that individual advocacy to a broader advocacy is kind of what this whole policy development thing is about. Yeah, sorry that was long-winded, folks, but I hope that dialogue helped people a little bit, maybe.
Another way, another way to advocate too is to have evidence-based medicine. You showed some studies up there that showed save money, got better outcomes, people were healthier. But some of your studies were kind of old, so I'm thinking that there are newer ones,
Yeah.
or we need to continue doing research and to continue getting.
Yeah, somebody gave me a
outcomes data.
brochure from a table out here from the CHAP program that I hear has some new local data.
And-
Anybody from CHAP in here? Blood? Okay.
And we know that, like, health isn't all about access to care. Health doesn't happen in the doctor's office. Health happens in your life and every day. And that's where CHWs come in and do that. So you need to prove that that works and that helps. And then you'll get money to continue.
Well,
Some
I mean,
states,
it's how-
Medicaid
Right.
does pay
Right.
for CHWs, some don't. So we need
Yeah.
to, continue proving that we're worth the money.
yeah, I had a very interesting conversation earlier too about the evidence of proof. So I buy a multi-million-dollar machine that's an imaging machine that isn't shown to do much for a person versus the CHW. So there are, I mean, what I'm trying to say is the burden of evidence is great and high for some reason for CHWs that I can't fully understand, although the conspiracy theorist in me says there's a reason. But I think, but trying to make the case as much we can when we can, but understanding that there's going to be some things that are beautiful happening with clients that we can't always have outcome data on. We can't do a double-blinded clinic, because you get data sometimes and somebody says, this isn't valid, you didn't, and you're like, their experience was valid, what's happened with the family's valid. But, so I am really, I think that we need to figure out how to do it. But I also know very pilot programs, funded programs that showed solid efficacy and evidence that were discontinued even after a very good body of evidence illustrated, proof of concept. So, yeah.
We've just been given the signal
Oh.
that we only can take one more question.
Okay.
I'm sorry.
How do you feel about cultural
And where you
stumbling
at?
blocks over here?
Okay.
Cultural stumbling blocks. I come from the Latino side, and we find that they don't want to go see doctors because they're not going to come home. They're going to die. They're going to give them drugs that they don't understand what they are. Even though you educate them, they still have a fear. And we've come across the older generations that we don't go to doctors. We don't, that's just what we don't do. We take care of each other at home. So how do you feel about those cultural stumbling blocks?
You sort of kind of just said it. I've seen many innovative programs that have a clinical provider and a CHW or other non-clinical provider actually do the intervention and even the visit at a community setting or at home. Bring in the stuff that's inside that building, the health center or hospital outside of it is one innovative way. But I think the other way is, once you learn about traditions and cultures and value and understand it, you can shape what you do in that clinical setting to that. It's just an issue of, are you willing to make those changes, which sometimes could mean changes in the clinical flow or other kinds of things that people might not want to get involved in. But you can, I think, take care of some of those folks who have some issues. I mean, I'm African American, I'm a descendant of slaves. I have a lot of reasons to distrust the medical establishment, but I'm doing, there was news about Henrietta Lacks. You all know about Henrietta Lacks? the reason why we have a lot of the information we have about cancer and other things, because this black woman had these amazing cells, never got any real attribution, and they finally, how many years later? I can't remember. So I have Tuskegee, which people think is way, way long ago, which really ended in 72, 3. I have a lot of reasons to distrust the system, but what I've done is decided to be active in trying to help be a change agent from within. So in the community, yes, but in the clinical setting, being at Children's Hospital for 20 years with my passion that you all can see for community wasn't easy because of how it's set up. And so I think that's ways that we can do that. But developing understanding of cultures, having more people who are diverse and from those cultures and different generations of those cultures on teams helps, but also bringing it to the people, getting some of those interventions that could happen out of the clinical setting to happen out of the clinical setting is another way. And I think some of the innovations, grantees, and others have done that. And I think there's data coming out on some of the folks who've done that well. So sorry to be long-winded again with that answer, but that is a valid point.
We just have one more question because she had her hand up over there for about 25 minutes. I'm just kidding, but here she is.
Oh,
Greetings, Darrell from Ohio.
Excuse me, we go way back. I do with many people in this room, but Melissa.
It's an honor to be here, Darrell. I want you to know my parents are out at one of our Amish screenings, and they're very jealous that I get to even spend a day in a room with you, let alone get to see you. So we're inspired by your words. Thanks a lot for all you do to help for CHWs. I had a question, though, because I think one of the messages I always want to say is, you know, you don't have to belong to a community to help, but you do have to know your place. And one of the challenges that we've had with clinical folks, with our CHWs is, you know, we work with Amish and Mennonite communities in the state. So English is their second language, but they speak it very well. And I think sometimes clinical folks think, especially in Appalachia rural areas, just because we speak the same language that you understand one another. We had an Amish woman who went to a screening and the radiology report came back a category 4, which means suspicious. She left thinking that she had stage 4 breast cancer. So, again, the clinical folks didn't see that aspect, that we really needed the CHWs to engage in that dialogue. And my question to you is, we talk a lot about CHW training, but are there established trainings for professionals in the clinical setting to help, you know, justify and talk about that need for that piece? Because if there is, we'd love to be able to utilize that in our program.
So I'm at a medical school that also has a nursing school. And by advocacy, there has been some things integrated around community into those curricula. But if you ask me, is there buy-in in the schools or professions for clinical providers around that concept? I don't believe so. I know that one good thing that's come out of the last 5 years around CHW training has been CHW training entities developing modules for supervisors. That I know some people who are even, you know, who run health centers have gone through that, particularly in my state. So it's not just a direct supervisor, but people above them. And I think that is one way to try to help that. But no, I don't think there's anybody focused specifically on that target population saying this is it. Now, maybe people in this room could differ. Maybe there are some innovators within schools of nursing or medical schools, but I don't know of any. But that's another, once again, another opportunity that we can potentially talk about. Yeah, thank you.
Thank you, Darrell. Give him a round of applause. Awesome.